with the Ministry of Health, serving as the focal point for COVID-19 surveillance and vaccination management. And so today I'd like to speak a little bit about COVID-19 morbidity, mortality, and one of the general issues that are coming around the world right now, pretty much vaccination hesitancy, and just try to make a link between COVID-19 and mental health system mental health systems. So first of all, I'm just going to make a introduction so you can see where we are on that so far. So the total number of COVID-19 positive cases that we diagnosed is 36,000, which is approximately just 5% of the total population. Average population is just about 800,000 persons in total. So sex distribution of positive cases, the majority of males, 47.2, majority of females, 2.8%, followed by males, 0.7.2. The number of recovered patients, which is significantly good, means we've had fairly well managed the COVID-19 pandemic in Guyana. 30,624, which is about 90% of all those persons who would have been confirmed cases. In terms of active cases, we currently have approximately 8,696 active cases across the country with administrative patients. In terms of hospitalization, we've had fairly good hospitalization rates relatively well compared to other countries. We have just about 70 persons currently admitted in hospitals with COVID-19. Just 12 of those are currently in ICU or critical condition. In terms of deaths, we've had just 945 deaths so far from COVID-19. And I say just because it's relatively good number compared to other countries and certain conditions like that business plan. But we continue to manage this. And of course, we're cognizant that we must be at some point in time on reporting for both say that COVID-19 deaths without the technology. It's coming forward, but it's pretty much voluntary. And of course, in some far-flung areas where we have persons who died from COVID-19, the two conditions of practice in those areas still are tested. In terms of where we are and where we're going, we've had pretty much about 3 waves in terms of what we've seen in Guyana. The last wave being what we suspect to be the introduction of the Delta variant. And over the last year, we've generally declining number of cases. So even though our testing rate is doing fairly well across the region, like I mentioned before, one of the limitations here is the fact that testing is voluntary, so it depends on the persons who are going to come. It's limited for that as we go forward. So we're going to go into vaccination. But we look at vaccination for adult populations, the youth years of the population. We have just about 307,505 first dose vaccines, which gives a coverage of 75.2%. Relatively small number compared to other countries, but of course our population is not so large. Total second dose administered 253,938, which was double approximately 1.9%. And of course, this number was 65.5% of all persons who have received the first dose, 18 years and older, now this second dose. So it's a good indicator that we have a lot of persons come up for their second dose. There's still a significant gap between first and second dose. So there's still work here. In terms of where we are in the regions, as you can see here, some regions, the numbers are you can see some regions are doing fairly well compared to others, and there are others that both first and second dose coverage not so well. And in region number 4, which houses the capital of Georgetown, you can see the coverage is the highest, first and second dose. And regions 2, 8, 10 are where we have the least second coverage for first and second dose. And what we found in those 3 regions are the regions where we have the majority of groups with hesitancy or anti-vaxxers or simply specific characteristics, whether it's political, religious, cultural, that influence vaccination and we were not taking vaccines. Generally speaking, the recent addition to our eligibility criteria within the 17 weeks range only recently started to incorporate the criteria 11. So far, we've had about 27,000 first dose vaccines administered this age, followed by about 19,000 second dose, which gives coverage of 38.3 and 26.1. 6.1%, which gives relatively clear coverage, but there's still a lot of work to be done here. And we've looked at a lot of the issues of this age group as economic risks versus how to get commission for children or analysts and how to get commission for kids. So have that So the next slide shows where we are in terms of progress for our age group. So we have relatively good numbers for 60 years and over, that's 70.4, important finances 5.8, 7.4, and in 12 38.7. Now I must say this is a reflection of the manner in which public vaccination programs were done. In February, characterized by the workers, followed by 60 years of overpopulation, versus comorbidities, and then followed by the age of 49, 39, and 27 years of vaccination. In terms of second dose, we have 5.1 for the 60 years over, with 5.1 for the 1.6, just 6.1 in terms of the 27. Which you can see that there's a gap between the first and second dose. And importantly, one of the things we notice here is 8 to 39 during that period, the first dose coverage should be better than now. And then we have very little second dose coverage, which represents the gain from proportion of population. And of course, those persons that are looking at versus where they work, school, study. So we suspect they present a greater risk in terms of transmission of COVID-19. And then the next condition that we saw also was in the 60 years when we have 78.4% first dose coverage, having come this beginning, and we only have 65.4%. So that's not a area to focus on in terms of what the cause or causes relating to that low coverage percentage. But we have an idea of more or less as to what that means. So one of the pieces that I want to discuss here is that and what we found in studies that we've done so far, I haven't brought all the results from the studies, but the majority of that is to one, there's myths, majority of it's coming from either social media, from television, or outside sources, from simply classes, which is very good for that. And the majority of these myths have pretty much been processed with simpler things to fertility, their vaccines, what they might be made with, contents of these vaccines, animals, and all sorts of things. Next thing would be religion. We have pockets of persons that belong to religious communities, so they're not serious. But they tend to be the more hesitant to vaccination, that's the not encouraged by their leaders, so probably equal to their resolution. Cultural habits. Another thing that we notice is that in certain communities, persons have sort of functional outside of coaching COVID-19, pretty much any disease or information community. And so they tend to say, let's just go with whatever happens, see what we're doing. And that is one of the reasons also because persons are not very interested about the details or the research or the facts regarding COVID-19 or COVID-19 vaccination. So that also comes in combination with knowledge because in some cases it may be accessible to having education on COVID-19 vaccination. And in those instances where they have knowledge, they have education on knowledge itself. So that's something for that too. Next to the health conditions, we found that a large number of the population, especially older population, 6 years over, they're, for some reason or other, they're quite concerned that if they may present comorbidities, whether it's diabetes, hypertension, or whatever, they're hesitant to vaccination because for some reason they think once they get vaccinated, they'll probably exacerbate the disease or cause some sort of compensation. Now, that is not the case. In fact, we try to provide information that say that listen, if you're presenting with a comorbidity or you have a chronic disease, you're pretty much in a you're probably in a high risk. So you need to be vaccinated. Because the majority of deaths in the survive that tend to be persons who are elderly, but 60 years and over, and the majority of them, let's say, 95% of all deaths in vaccine are presented at least one or two comorbidities, principally So that is something that we need to look at. But I think when we're looking at patients or persons coming into the centers and units that is planning here, we need to evaluate all these different elements so that we can understand not only how we approach COVID-19 vaccination, but also all the other diseases or whatever gives us an idea of how we can plan and decide on an approach against COVID. So we've determined in terms of COVID-19, the three groups here in terms of categories to look at. So when we look at persons, we look at pre-COVID-19, during COVID-19, post-COVID-19. Now, I'm not a specialist in terms of mental health, but I would say that in terms of pre-COVID-19, what we see are some of the factors that I explained before. So when we evaluate the person, we need to take a look at that and evaluate what are the elements that are present that might cause these persons to not adhere to public measures for transmission or if they're not accepted into vaccination. In terms of during COVID-19, from the large number of persons faced with this stigma, where persons in the family don't want any much to do with them, or they're trying to distance from them. There's the issue of discrimination, also causes fear. Some disparities, you might also find some disparities in terms of healthcare, where we have had just a small number of healthcare workers who can versus COVID-19, or from various persons that come from. As you know, these Uganda had a week of migrants coming from Venezuela and some other different countries, principally from Venezuela. And it was created somewhat of an upsurge in terms of difficulties or cultural issues around native persons in various communities. And we find to see that a number of them, for one reason or another, may not be inclined to visit health centers or contact with physicians to get treatments that they were doing contracted with these probably language barrier or in terms of COVID-19, post-COVID-19 comes the same factors. We speak about stigma, we speak about discrimination. There are some reports that may have some racism related to that in certain communities. And of course, all the elements to be evaluated. And in terms of mental health, I think we focus on anxiety, depression, and what are some of the factors that affect these persons? What other health conditions do you know? Mental health states following COVID, fear is one of the most important things to learn across the board and how to learn as much as possible. Like I mentioned before, so I won't get back into every single one of these, but I think I put two topics here and I raised the question of what role is play existing or new technical conditions in care. And so now pretty much we're looking at stigmatization, discrimination, health disparities, phobia, which is not that prevalent in that, but it's mostly certain communities. And I think one of the things that you can be very careful with foreign nationals and the language we use also when we're language with so let's say UK vaccine or American vaccine, it's sort of the Chinese virus because it goes that introduces a certain section of the population and we can create their cost of sort of exacerbations with the system. Knowledge of COVID-19 is very important socioeconomic effects, and of course, my intention here is not only have this the persons coming to consults for mental health, but instead have training for mental health practitioners, for healthcare workers at the primary level, they have contact with these persons on a daily basis, so that they're able to evaluate these elements and be able to identify some companies probably before then it's necessary to have that evaluation. Some priority groups that pretty much all researchers across the world have mentioned by now, and there's children and adolescents, of course, that has to do a lot of the interruption with common activities, the coping mechanism, the interact with their schools, the teachers, their friends, and now they're in a new setting where they have to be home all the time. So the form of education has changed from personal interaction is now a digital platform or virtual, and we find there are a lot of challenges there. Number of people that we also consider so that results from standardized examinations using the line in terms of performance. And so that's the indication also that there are challenges. And then another part of that is the accessibility to virtual and digital education, not spread across the elderly disabled, of course, we have disadvantages, especially those who are on their own, so this and of course that frameworks like many other countries that frameworks are some very similar to overwork like some kind of depression, anxiety, other mental conditions. So it's putting systems in place that identify these issues and also treating them and having those follow up with them. It's not just so hard. So there's and I think my last slide has this in terms of surveillance, and the important thing here is creating a system of surveillance to collect this data, and that has to do all of it practical data, works from the health sector, it's the funding, experimenting, identifying these persons, stratifying the risk, and those having a military system, habits, knowledge, office services, psychological services, or whatever it is, social work, etc. One of the fundamentals is the it's absolutely necessary to target mental health. That's one of the conditions. And even though we know that these persons that's biological, psychological, and social, focus more on physical, conservation, social, and psychological. These are some of the important things affecting the lives of these persons, how they interact with society, what is this thing, what is their responses. So I think that brings me to the investigation. I can't help to license on this advanced and save lives, and I think it's vaccination possible for everyone from the first and second dose for immunity. It's absolutely necessary. So I think thank you very much.
Yeah. Thank you for that. I think one way to start our conversation.
I'll just switch to the internal microphone here. Okay, so sorry, we've lost video for a second. It's okay. But let's talk. First of all, thank you for that. I would add that it's not just here in Guyana that people concentrate on the physical. Worldwide, they concentrate on the physical, especially during COVID. They neglect everything else. One of the things that you brought up is the reason why we're here is that we are doing a project, a research project here, looking at suicide and suicidal behavior all over Guyana. And one of the challenges that we've had thus far is the data. How do we know that a case has happened, that not only has someone died by suicide, but that someone has attempted to harm themselves? That's an even harder question. And we have Professor Lakshmi, thank you, who has done some wonderful work in India at the community level. And then we have Mrs. Tull here from the Bureau of Statistics of Guyana, who can help us, better understand how we can gather the data that is needed, not just for suicide and mental health and attempters, but also for COVID and other diseases. New York City has, they've done what's called a syndromic surveillance system. So as opposed to just reporting on that someone has attempted suicide or that someone has COVID, they collect via text words, at the emergency rooms, at the clinics, at the, we can expand it here to the village levels as to what are some of the symptoms that bring someone to receive care. They have a runny nose, they're coughing, they're sweating, they're whatever, they're lonely, they're depressed, or whatever. And that information gets, in New York, gets transmitted obviously through the internet. Here, we're thinking that maybe with an SMS, because we know in the hinterlands especially, internet is not a realistic thing. But cell phone with SMS may. So the idea would be that they would text different symptoms to a central place at the Ministry of Health, that the system would then collect this information and flag cases for someone to then be able to report and go investigate to see if is it COVID, is it suicidal attempt, what is it? So I'd like to ask Lakshmi here to maybe tell us a little bit about what the work that she's done in India, so that and I'll try to work on the camera.
I don't have slides. The fact is, like world over, suicide and attempted suicide are underreported in my country also, and it's a huge country. And the fact is, suicide is still a kind of a crime, though it is not cannot be punished. So actually this in many of these countries you will find suicides more than the number of official reported attempted suicide, because it goes under the radar as accidental poisoning or whatever it is. So when we wanted to study a particular, we devised an intervention in a huge group of population of about 350,000 in 150 villages in a district in Gujarat. We knew that if we have to really assess whether the interventions were effective or not, we need to have a much more accurate data than what is available in the official system. The official system, the data is one is the police records for suicides, and for attempted suicide, the general hospital emergency data and some private hospital emergency data. But we know a lot of it is underreported. So in these 115 villages, we did a pilot in 4 other villages and then put the community surveillance system, which is actually third-party informants. That is, we map, if there are 114 villages, we map the villages in terms of where the different religions, castes, socioeconomic people are divided. And then based on that, we make sure that the entire village is covered with informants. And who are these informants? We have 10 categories of informants. First is the local GP, then the private practitioner, then practitioners of alternate system, because it's very popular in India, like allopathy, Ayurveda, Siddha, Unani, faith healers. So one of them, nurses, and then we have somebody called as ASHAs, who are community health workers, which are accredited health workers. So them, and they are the ones who know most about what is happening in that particular village. Then the local teacher, then the local priest, then the local cremation ground or the burial person, because they know where it is. So we have a category of 10 people, and then we selected researchers with not big, just graduates, from that area, and gave them a 2-day training on how to go and approach these people. And so then they were all given a tablet, and each surveillance officer were given about 10-15 villages to do. So their job is to go to that village once in a month, talk to all these informants, and find out whether there was any suicide or attempted suicide in that village in that month. Okay, and amongst the 10 people, it is very easy to find out. I mean, nothing happens without somebody in the village knowing that some suicide or attempted suicide has happened. And then, of course, we have the big job of triaging it, because 2 people may say this happened on Wednesday, then 2 other people will say it happened on Sunday. So we have to triage the data. So we had a protocol for triaging the data. And the least of it is name. We don't want the name, because they will be called one name in the house, one name in the official records. So it is the village where they are from, the method, the date, the time. So we had a priority list of what things, so that we don't overcount. So then the surveillance officers come back, and within 48 hours, they have to feed into the software system, because we don't want any recall bias. We don't want anything to happen. So within 48 hours, it will be fed into the software system. And then the people who triage and do that are a different set of people, so that they don't, there is no bias. So we set up the system in 114 villages. And to give you an example, according to the official records, the number of people who died by suicide in that 1 year, officially, according to the police records and given, was about 20 or 25, whereas with the community surveillance system, we identify an additional 50 persons who have died by suicide. Okay, and then this, and then people will say that, you know, how do you know they actually died? Okay, so with those deaths which was from either a single informant or where there is no official resources, we went to the death registry. Now, death registry is very sketchy. You know, just the name, age, and on the date they are died. So we verified and made sure that they have really died. Then you know that it has happened. Then for the attempted suicide, it was a comprehensive thing because apart from the community surveillance officer, we also every 3 months we looked at the hospital records, both private and public, and trying to triage the things. And there we found that we had there was definitely more identified in community surveillance, but we had missed out a lot of suicide attempts which were in the hospital records, but which the community did not pick up, which is to some extent explained by the fact that when you make an attempt and you go not necessarily to the nearest hospital, you try to go away to a far off hospital so that there is, and not many people know about it. And most of the time, if the other informants know, they will say that they're gone for stomachache or some fever or something like that. So the third party informants were what I won't say less, because it was not as much as death by suicide. You know, we had the community surveillance missed out about 20-25% of suicidal attempts which were recorded in the hospitals. Okay, so I think what we need to do, particularly in a country where the registration systems is not good and where the registration system is a little poor, we need to have a combination of both the community surveillance and the official system to arrive at a more accurate figure about suicide and attempted suicide.
Thank you. Absolutely. Mrs. Tull, so just to give us a better idea of the landscape that we're facing in terms of Guyana, you know, I've seen data, for example, for suicide at the regional level, but to get it down to the village level is a bigger challenge. Obviously, we don't want to identify anyone or share anyone's identifying information at such a small level, but you know, with the idea of the community surveillance system that was just described, we would need to get input and workers or folks from the village that can help feed that sort of information to the national level. And I know that each region will be different, but how many villages are there, say, like in region 2, for example? Is there, I mean, a rough figure, obviously. You don't have those numbers right in front of you. Of course, I know that. Yes. Mm-hmm. Mm-hmm.
Before you do that, you will enumeration so that you can use accurate information. When we go to these households, we let them understand that the data that we collect is unfair. So we go to the households, we train the enumerators and the supervisors to collect the information, and they speak to somebody that is mature and can give you the information that you require. As I mentioned before, tell the person that the information is confidential. So when you go, you put whoever the respondent is, you try to put them in a safe place where they are comfortable and they're not fearful, or you try to make them as much as possible at ease. Because remember, this is a very sensitive information that you're collecting. Sure. And persons would get emotional. So you go and discuss with the person that can give you that information, and you collect information. What you can further do is like try to see what information the police force has, as well as Ministry of Health, and to see if what you collected, if there are gaps, you can try to fill those gaps, right? But when we're disseminating information, we don't use names.
Of course.
So whoever is analyzing that data, they have to analyze, but try to eliminate process of using any names so that the person can be identified. So that is how I think we should do. Try to get information both from the household as well as police stations and Ministry of Health. And also, they have these NGOs, like we have Help and Shelter, where persons will go and like report attempters or so. So you try to get information from the NGOs. So when you get all this information now, you try to see what is accurate, where the gaps are, and try to fill the gaps. So that I think should help in getting the information that's required.
Thank you. I know that we're running out of time, unfortunately, but I just wanted to get Steve's input as to maybe some of the technical challenges of taking sort of the data. So, if we set up a system here, when we set up the system here, that all the data is fed in from the community level down to the central repository at the Ministry of Health, so that we can better identify hotspots of either disease or suicidal behavior. What would be some of the technical challenges that we would need to consider to be able to overcome these hurdles and be able to generate accurate reports in a timely manner?
Well, with this sort of data, obviously you need to think about privacy and for instance, any information that you can use to identify the deceased persons that would need to be kept separate and much more secure from more aggregate level information. And there are best practices we could follow on that. We would want to look at what open source tools have already been built. This is a problem that a lot of people are working on, and it seems very doable in terms of visualizing it on a map. Automatically analyzing the data using artificial intelligence and that sort of thing is more difficult, and we shouldn't expect as much from that. So I think that whatever we're doing with the data, we should expect it involves a human expert analyzing it. Yeah, I think financially, like the cost of managing data and tools is getting quite low. So I don't expect major IT expenses.
Thank you. So yeah, I mean, I agree. We shouldn't just rely on artificial intelligence like machine learning, but there are a lot of algorithms out there that I think can help, identify potential cases that need to be followed up by the human, the healthcare persons. Thank you. Because we obviously, when it turns to suicide, if someone's reporting in, again, my idea is not to just build a system for identifying potential suicidal behavior. My idea is to build a system that is expandable to everything, and then we can also identify those that are potentially in harm's way in terms of suicidal ideation, attempting, and unfortunately dying by suicide. So a lot of that needs to be built in so that a healthcare worker that is looking for possible cases of a suicidal attempt is not worried about are they coughing or do they break a leg or so on. As you know, we've seen through the conference, there are some instances, many instances where something comes into the emergency room, is reported as a car accident, but the reality is it's a suicidal attempt. And in those cases, also things like that needs to be flagged. We need to try to think outside the box and bring all the tools we possibly can, whether it be at the community level with the health workers, whether it be at the national level with all so the census is going to happen in a few months, right? So that sort of level information, if you know, if we collect all that, if we can collect all that wonderful census data at you know, for all these wonderful individuals throughout Guyana at the village level, we should be able to tie something in that can harness all the information. So unfortunately, we have to move on to the next presentation because I know that there's some folks that are already logged in, and I thank you very much, and thank you. If you have any questions, please feel free to send us an email at through our Facebook. Thank you very much.